This morning, hopefully you already find out what tumor you got, where it's located, how you've been treated, how you've been diagnosed. And so this afternoon, we will focus about some therapeutic aspects of it. And we have 5 outstanding speakers that we have lined up for you. So you cannot fall asleep. The first one is my colleague from Los Angeles. Dr. Ed Wallen is the director of the Neuroendocrine Carcinoid program at Cedars-Sinai. He is really one of the pioneering chemotherapy therapeutic aspects of this tumor. He is my dear colleague, just my neighbor. And he will be talking to us today about what new in chemotherapy and biologic response modifier therapy in NETs. Ed?
Okay, it's really a tremendous honor and privilege to speak to everybody here today and to have been invited by Dr. Woltering to stand before you here. We're going to be talking about what's new in chemotherapy and biologic response modifier therapy for neuroendocrine tumors. I'm going to try to give you some basic principles, talk about a lot of ways that we think about treating this disease, and over the course of the meeting you'll hear a lot about new clinical trials that Dr. Coles is going to be speaking about and other aspects that will be coming. Okay, first I'd like to leave you with a few basic underlying principles that I just want you to keep in mind when we talk about chemotherapy for neuroendocrine cancers. And also what we mean by chemotherapy. Chemotherapy normally means using drugs which kill cancer cells. It's not the name of the substance, it's the name of the treatment technique of using systemic treatments. So depending how you define it, it might include only so-called cytotoxic chemotherapy, which is traditional chemotherapy that is often given intravenously and often has a lot of toxicity. But it can also be a generic term that includes all the new biologic response modifiers as well. I'm going to be speaking about chemotherapy right now in the more traditional way, talking about traditional types of drugs which can occasionally be useful, and then we'll talk about the other things under the general category of biologics. Chemotherapy for neuroendocrine tumors does not usually cause a major reduction in tumor size. In oncology, we call this a low response rate. Usually the tumors shrink little or none. However, despite the low response rate, the time to progression, in other words, the amount of time the cancer can stay under control in a remission, can be markedly prolonged with chemotherapy, extending survival and increasing quality of life. Another basic principle is that tumors that are more metabolically active are more responsive to chemotherapy. The more metabolically active tumors typically are the ones which we call intermediate grade instead of low grade, like you heard in the pathology talk this morning. Ones that are called moderately differentiated instead of well differentiated. Atypical carcinoid is sometimes used in talking about lungs. And tumors that have higher levels of Ki67 all make the tumors more likely to respond to chemotherapy with shrinkage. Carcinoid tumors have no FDA-approved drugs in the United States, so any type of systemic therapy that we use for treating carcinoid tumors is by definition investigational or an off-label use of a drug. Amazingly, even Octreotide, which is used almost universally in treating neuroendocrine tumors, is not FDA-approved for treating neuroendocrine tumors. It's only approved for treating the symptoms of diarrhea and flushing. Pancreatic neuroendocrine tumors, on the other hand, have 3 drugs which have been approved, and we'll be talking about it a little bit more later. Everolimus, Sunitinib, and Streptozotocin have been approved. So this is the one type of neuroendocrine cancer that does have some approved drugs. There's a combination of temozolomide and capecitabine in well-differentiated neuroendocrine tumors, which is effective in many cases. There's combinations of platinum drugs and etoposide in high-grade neuroendocrine tumors, which are commonly used. These are sort of exceptions, and again, none of those drugs are yet officially approved by the FDA. Pancreatic neuroendocrine tumors often respond better to chemotherapy than other kinds of neuroendocrine cancer, and is one of the reasons why approval for certain drugs has already occurred for that disease. Now, the next major class of drugs for treating neuroendocrine tumors are targeted biologic agents. Why do we use targeted biologic agents? First of all, the unique chemical makeup of neuroendocrine cancer cells makes them particularly susceptible to therapy with these kinds of drugs. Neuroendocrine tumors have increased numbers of blood vessels, and they have increased production of substances that stimulate blood vessel growth. The cell membranes of neuroendocrine tumors have increased tyrosine kinase growth factor receptors, so by targeting those receptors, we can stop neuroendocrine cancers from growing. There are genes involved in maintaining the malignant state that are overactive in neuroendocrine tumors, as Dr. Warner alluded to earlier today. Also, neuroendocrine tumors have lost their dependence on external stimuli to proliferate, and instead they generate internal signals and just keep dividing, multiplying, and making more and more cells without internal controls. And they don't respond to normal stop signals that keep cells from growing indefinitely, so they just keep growing. They also don't stick to the underlying matrix, and that gives them the opportunity to invade and metastasize. Tumors, cells in the body grow on a microscopically thin surface called a matrix that allows the cells to grow in an orderly way. This doesn't apply to neuroendocrine cancer cells. And there are no limitations on the number of cell divisions, so theoretically these cells can replicate forever. There's nothing to stop them from getting bigger and bigger and bigger. And all of these different things can be targeted, and we're going to be talking about many of these as we go on. In addition, neuroendocrine cells have defective enzymes that are necessary for cells to commit suicide. Believe it or not, cells in the body not only have instructions to grow, but they also have instructions to die at the right time when it benefits the whole organism. So this is called apoptosis, and the regulation of apoptosis is defective in the neuroendocrine tumor cells. There are changes on the surface of the neuroendocrine tumor cells that help the cells be resistant to immune destruction. So when cancer cells arise in the body, there are mechanisms for destroying those foreign cells in general, but if you have a neuroendocrine tumor cell that the immune system can't recognize, it can escape destruction and continue to grow. And they have mutations that form that make them resistant to particular kinds of chemotherapy. So you can see that because of all of this, there is enormous potential for targeting these malignant cells with biologic agents. Every one of those things I mentioned is a potential target for attacking the cancer. The problem is, how do we identify what drug, what target, and what do we do? There's a new concept I wanted to share with you called molecular profiling of cancer. Molecular profiling of tumors is used to identify potential biomarker targets and guide treatment for resistant types of cancer to help determine what would be best thing to do. In a study that was performed by Dr. Van Hoff using a variety of tumors, not only neuroendocrine tumors, molecular targets were able to be identified in 98% of cancers by doing a profile of the tumors. 27% of patients experienced a longer progression-free survival guided by molecular profiling when this was used for guiding treatment instead of just randomly using a kind of chemotherapy. Okay? So how do we do molecular profiling? Just to give a general idea to this group about some terms that you'll be hearing in the near future more and more commonly, I'm going to share a few of these with you. One is called immunohistochemistry, or IHC. This is like the type of chemistry that we were hearing about in the pathology discussion today, to look for Ki67 or MIB1. That's done by immunohistochemistry. It allows you to specifically do a chemical reaction with chemicals in the tumor cells, and they turn a dark brown when the reaction product is present. So this can be used to stain all types of biomarkers, not only Ki67. You can also do DNA sequence analysis that can detect mutations in a single point in a gene. This mutation can maintain the malignant state and cause resistance to therapy, and also these genetic mutations can be targeted for certain types of molecular agents. There's a technique called FISH, not something that we eat for lunch, but fluorescence in situ hybridization that detects amplification of a biomarker. So if a cell is making too much of any one of these substances we're referring to, you can detect it that way. There's also a technique called microarray analysis that measures the expression levels of thousands of tumor specific and treatment-specific genes at the same time. And this way you can do an enormous screen with many, many, many potential outcomes and get a result at once. The amazing thing is it's possible to do this commercially. Tumor specimens removed at surgery can be sent for molecular profiling, and results can be useful in guiding therapy. And experienced surgeons do this type of thing often quite routinely now in conjunction with medical oncology and pathology to allow these analyses to be done at certain laboratories that are set up specifically for doing this. Another thing that is of great interest is in Johns Hopkins, there was a complete genetic sequencing done on 10 patients with pancreatic neuroendocrine cancer to look for genetic defects in the neuroendocrine cancer that could be stimulating the cells to keep dividing indefinitely and attain their malignant state. And they found that these 4 mutations were MEN1, which we've heard about before in the MEN1 syndrome, which is a genetic familial syndrome, but also sporadic MEN1 mutations can happen within a pancreatic neuroendocrine tumor, or other neuroendocrine tumors for that matter, even when MEN1 syndrome is not genetically inherited in a familial way. And then there's several other mutations, as well as one for mTOR, which is a target we have therapies for now using drugs you'll be hearing more about, like everolimus. Efforts to identify these mutations and target therapies for them is certainly underway. So stay tuned, the era of molecular profiling and targeted personalized medicine is here. Now, what are the problems with molecular profiling of tumors? Is this the answer? Everybody should get a molecular profile and we'll know right away what to do. The problem is most of these assays have not been adequately validated in neuroendocrine cancer or in many other kinds of cancer. And selecting incorrect patients for treatment can therefore occur. There's an increase in the cost of care using these tests that may not be paid for by insurance. There are problems with logistics of screening, trying to identify a rare patient who might benefit from a mutation. For example, if there's a targetable mutation that happens in one person in 100, do you do an expensive test on 100 people to identify one person who might benefit, and what is the threshold of risk versus benefit? It's becoming easier as time goes on when we get more and more items that can be targeted at one shot, but right now it still sometimes is a challenge figuring out how to identify who should be tested with what. Targets for treatment are evolving in metastasis and are frequently multiple. What this means is if you have a cancer, there can be some areas in the body where a metastasis might have one mutation and other areas in the body where metastasis have another mutation. There might be more than one area within the same tumor that has different mutations, and over time tumors can acquire different mutations and need different targets. So you can do a whole analysis on a primary surgical specimen, which is very convenient since you have a whole specimen sitting in a bottle ready to be analyzed, but yet years later when the cancer recurs there might be other mutations which need to be targeted, which are actually driving the cancer at that point. So those things all complicate the issue, in addition to the ethical issues raised by repeat biopsies each time with the risk of complication and expense. Another problem is that we still don't have enough treatments to keep up with the growing number of targets which could be identified, and as time goes on and we get more, we'll be able to do more. I'm going to give you a brief survey of some of the new directions that we're going right now, and again, you'll be fleshing out the details as time goes on, and also an opportunity to ask questions. This is a little summary that was presented at the ASCO meeting by Pamela Kuntz, showing the increased numbers of publications and research trials going on in pancreatic neuroendocrine cancer. You can see that in 1995, there was essentially nothing happening in pancreatic neuroendocrine cancer, and in clinicaltrials.gov we're up close to 600 different references now to trials for pancreatic neuroendocrine cancer, along with an explosion in the literature. And now we're seeing a huge increase in treatment options and research trials. The first thing I'm going to talk to you about briefly is mTOR, which I mentioned a little bit earlier. mTOR has a fascinating story. It stands for mammalian target of rapamycin. Rapamycin is an antibiotic, okay, which was isolated from a fungus in the Easter Islands. The big island in Easter Islands that has all the heads made of stone is called Rapa Nui. So when it was found from the soil of Rapa Nui, it was called rapamycin. Since nobody had any idea what rapamycin was doing to cells, they called the enzyme in the cell being inhibited mammalian target of rapamycin. So now you have something really fancy. You have a drug called an mTOR inhibitor, and you have a target called mTOR. It's a little bit circular, but anyway, that's how it started out. Subsequently, mTOR has been shown to be one of the key regulatory enzymes in cells. It's ubiquitous in every kind of cell, and neuroendocrine cells have mutations making mTOR activity tremendously increased compared to other cells in the body. mTOR is involved in nutrient assimilation, cell growth, cell death, metabolism. It's just a remarkable regulatory enzyme. Rapamycin, after it was isolated, which goes by the generic name of sirolimus, has several congeners that have been made. The one which is most usually studied in neuroendocrine cancer is called everolimus, the original product being sirolimus. Everolimus in pancreatic neuroendocrine tumors has been studied in detail in the RADIANT-3 clinical trial, comparing everolimus versus placebo. The amount of time patients were able to remain progression-free, cancer under control, was increased from 4.5 months roughly to 11 months. And there was a 65% reduction in risk of progression. And normally people tolerated this once-a-day oral medication quite well with generally mild side effects. So this, on the basis of this data, this is what it looks like on a graph. The people with the mTOR inhibitor, everolimus, being the red line, and the people not getting it, the light-colored line. So this led rapidly to FDA approval last year. The people in blue were people that had a shrinkage of cancer, and you can see with everolimus it was excellent. In the placebo group, very few people had a shrinkage of cancer, and that was probably due to the fact that many people were taking Octreotide at the same time, which has activity as well. Everolimus has also been studied in carcinoid tumor. There was a large study called RADIANT-2 involving 429 patients randomized between Octreotide versus Octreotide in combination with everolimus. In the people that got the combination, there was a 5-month prolongation of progression-free survival, the amount of time people can stay under control. It also looked like it was useful in lung and colorectal carcinoids, in addition to the small bowel carcinoids. However, the data from that study is still preliminary, and a new trial is underway, known as RADIANT-4, which is hopefully will definitively establish the value of everolimus in carcinoid tumors of the intestine and lung. Another drug which targets the ability of blood vessels to grow in tumors, an anti-angiogenic drug, is called Bevacizumab. It goes by the brand of Avastin. It's a monoclonal antibody, an immune therapy that targets the VEGF, vascular endothelial growth factor. It's usually well tolerated, although it can cause some side effects like hypertension, blood clots, bleeding, impaired wound healing, and protein in the urine. Serious side effects, which some of these obviously are not very common, and people have to be watched for carefully for toxicity when it's used, but it's another major advance in the field. In a preliminary study, there was a 24% major response rate in neuroendocrine tumor reported by Dr. Kulke. And combinations with Avastin have also been done. Bevacizumab, oxaliplatin, 5-FU with leucovorin has been reported from the group at UCSF. Bevacizumab in combination with oxaliplatin and capecitabine has been reported from the group at Stanford. These all have activity, and these drugs are widely available, and it's another chemotherapy program which can happen. In addition, there's a phase 3 trial of Octreotide LAR plus interferon alpha, which has anti-cancer activity and immune stimulant, versus Octreotide LAR plus Bevacizumab in carcinoid tumor. This is a study sponsored by the Southwestern Oncology Group. It's recently been closed to accrual, and analysis is forthcoming, but it looks like this is going to be another excellent means of assessing the role of Avastin and interferon alpha, for that matter, in treating neuroendocrine cancer. So we have to await the results of that. There's another trial which is involving Bevacizumab, which is ongoing right now, using Everolimus in combination with Bevacizumab versus Everolimus alone for pancreatic neuroendocrine tumors. Remember, Everolimus has been approved now for pancreatic neuroendocrine tumors based on the data that I showed you, and now we're trying to improve upon that by adding Bevacizumab. So we're treating patients with that now. Sunitinib in pancreatic neuroendocrine tumors, another important drug. Remember, one of the targets that I talked to you about were tyrosine kinase inhibitors. Tyrosine kinase involves multiple stimulations of growth factors, and these are drugs that target this. Pills once a day, biologically active. It works specifically on tumor cells. Sunitinib blocks molecular targets needed for growth and metastasis of neuroendocrine cancer. It inhibits the vascular endothelial growth factor receptor that we previously mentioned, also platelet-derived growth factor receptor, which play important roles in blood vessel development in tumors. And if you don't have blood vessels, you don't have oxygen, you don't have food, and you don't have tumor growth. So this is a valuable and generally well-tolerated program. Everything has side effects, including Bevacizumab. Can cause some problems with low blood count, hypertension, abdominal pain, diarrhea, soreness of hands and feet, mouth sores. But if the dose is adjusted carefully and doctors are familiar with using the medication, it's usually a well-tolerated pill. In this medication, where 79 patients were randomized to either get Sunitinib or placebo, the average time to progression was 11.1 months with Sunitinib and 5.5 months with placebo. We don't know, and this is again a graphical representation of the same, we don't know whether it's better to use Everolimus first, Sunitinib first. They're both approved for pancreatic neuroendocrine tumors. Don't let anybody try giving you the combination of the two together, because it looks like it increases toxicity when you use the two together. But the use of these drugs in combination with other active agents is being actively explored. The use of cytotoxic chemotherapy for neuroendocrine tumors is something that we mentioned a little bit in the very beginning. Streptozotocin is one of those drugs which was approved by the FDA for pancreatic neuroendocrine tumors. When it's used in combination with doxorubicin and 5-FU, there was a 39% partial response rate, meaning at least 50% of the cancer shrunk, which is a good response. Median response lasted 9.3 months. You have to be careful using this drug because it can cause permanent injury to the kidneys, and if that happens, it can compromise your chances of having peptide receptor radiotherapy, which, as you'll be hearing about today, is not safe if people's kidney function is significantly impaired. Another important chemotherapy program, again not approved, but active and widely used, is temozolomide in combination with capecitabine. These are drugs which go by brand names, Temodor and Xeloda. Both of these chemotherapy drugs are pills. Again, usually well tolerated, although side effects can occur. And 71% partial response rate, 29% stable disease for at least a year, reported by Dr. Stroker. What is somatostatin? I'm going to talk a little bit now about somatostatin analogs. Somatostatin is a natural hormone which stops the growth of hormone secretion by neuroendocrine cells. However, it's destroyed in the body within minutes, making it very impractical to use as a pharmaceutical agent. So somatostatin analogs have been developed, which are modifications of the somatostatin molecule that make the drug stable for weeks or hours, depending on the particular modification. So these modifications are called somatostatin analogs, and we have several of them which we are using. Somatostatin receptors are present on neuroendocrine cells. There are 5 different types of receptor. The mechanism of action of somatostatin analogs has been very heavily explored. And the bottom line is it makes a very, very specific and targeted therapy that will allow attacking of neuroendocrine cells by attaching to these receptors which are on the cell membrane of the neuroendocrine cells. The drug which is most widely used in the category of somatostatin analogs is Octreotide, and the long-acting formulation Octreotide LAR, which is typically given intramuscularly on a monthly basis every 4 weeks. And again, approved for carcinoid syndrome, but widely used in other types of neuroendocrine cancer, and very effective in treating diarrhea and flushing. Now, why do we say it has activity in neuroendocrine cancer? There was a randomized trial done in Europe known as PROMID. The PROMID study involved 85 patients with carcinoid tumors starting in the small intestine. Half of the patients got Octreotide LAR, 30 milligrams every 4 weeks. The other group was placebo control. And the goal of the treatment was to stop cancer from growing. The average time to cancer progression was 14 months with Octreotide versus 6 months with placebo. And you can see that just with Octreotide alone, the response rate is very similar to what is being achieved by many types of biologic agents. For example, Everolimus and Sunitinib in pancreatic neuroendocrine tumors. You can accomplish similar results with a somatostatin analog in a carcinoid. Another somatostatin analog which is being investigated is Lanreotide. Lanreotide Autogel is a subcutaneous sustained release formulation of another somatostatin analog, which works in a very similar fashion to Octreotide, but it has the advantage that instead of a deep intramuscular injection, it's a subcutaneous injection. A single subcutaneous injection every 4 weeks can maintain a therapeutic blood level of a somatostatin analog. So that has obvious potential for quality of life improvement. There are 2 major studies that are being conducted. Neither one has reached the point of data being finalized for analysis, but there are 200 patients randomized to receive either Lanreotide Autogel 120 milligrams subcutaneously every 4 weeks versus placebo to evaluate progression-free survival and quality of life in neuroendocrine tumors. And again, these are non-functioning ones, no carcinoid syndrome. This can be analogous, if you like, to the PROMID study done with Octreotide, where we're trying to control neuroendocrine cancers with neuroendocrine cancer growth with a somatostatin analog. The second Lanreotide trial was in carcinoid syndrome. People were randomized between Lanreotide and placebo. They all had a positive Octreotide scan, had stable tumor in the 3 months preceding treatment, and again had carcinoid syndrome, who hadn't been treated with Octreotide before. And we have to see how that turns out when the results become available shortly. So that's Lanreotide. The next one I want to talk about is Pasireotide. Pasireotide binds much more tightly and with higher affinity and to more types of somatostatin receptors on the surface of neuroendocrine cells. Neuroendocrine cells have 5 different types of somatostatin receptors called SST1 through 5. Octreotide binds almost entirely to the so-called SST2, the type 2 somatostatin receptor, and Pasireotide binds quite tightly to 4 out of the 5 receptor subtypes. And since neuroendocrine cancers don't have only type 2, but have other types as well, there is the potential that this can control carcinoid syndrome and even carcinoid tumor growth that couldn't be controlled with Octreotide. Studies are still underway right now. There was an early phase 1 trial done of 20, 40, or 60 milligrams to treat carcinoid syndrome. In this trial, it looked quite promising. Side effects were almost identical to the side effects of Octreotide, with the exception that even though you can have an increase in blood sugar from Octreotide, that particular side effect is bit more common with Pasireotide, so blood sugar has to be monitored. Then there was a large randomized trial comparing Pasireotide LAR versus Octreotide LAR in carcinoid syndromes for people that had inadequate control of their diarrhea and or flushing from carcinoid using Octreotide or Lanreotide. The randomization was between a dose of Octreotide, which is higher than the approved dose, 40 milligrams every 4 weeks, versus Pasireotide. Pasireotide and SOM230 are synonyms. The study was closed without clear benefit for Pasireotide for many technical reasons, but we really don't know the answer yet about exactly where Pasireotide is going to fall in the therapeutic armamentarium. There is a Pasireotide trial which is ongoing right now, which is treating the pancreatic neuroendocrine tumors, which we call functional. The insulinomas, gastrinomas, VIPomas, glucagonomas, ACTH-producing tumors that make you have too much cortisol, and that study is still accruing, and we don't have an answer yet. These trials are using 60 milligrams of Pasireotide every 4 weeks intramuscularly. Other ongoing trials that we have to watch with great excitement with Pasireotide. There's a phase 2 multicenter trial of Everolimus alone versus Everolimus plus Pasireotide in advanced pancreatic neuroendocrine tumor. This is known by the nickname of Cooperate-2. Still no data from that study yet. It's accruing, and it's something we have to watch with interest. There's also a phase 1 high-dose Pasireotide trial, which we're doing now, to evaluate if we can get better control of cancer, longer control of cancer, more complete control of cancer if Pasireotide is used at a higher dose than normal. Remember, normal in the past has been 60 milligrams every 4 weeks. This is an escalating dose schedule, and as time goes on, people are going to higher and higher doses to try to determine what the optimal dose will be. And so far, that study is going right along. I wanted just to tell you very briefly, I don't want to talk too much about PRRT because you're going to be hearing so much more about it from at this meeting, but just to let you know that this is also based on somatostatin receptor binding using Octreotide. The only difference is when we call it PRRT, we're taking the Octreotide type molecule and attaching a radioactive isotope to it. But the targeting agent that is targeting the cancer is the Octreotide whenever people are having PRRT, and the peptide receptor radiotherapy is based on this. So the Octreotide, the Somatostatin, if you like, the brand is, or analog, is being linked very tightly with either Yttrium-90 or Lutetium-177, and this is being used as a therapeutic agent. In the early data, which you'll be seeing much later data, treatment in 4 cycles, given approximately 6 to 10 weeks between the cycles, 4 treatments altogether, in 504 patients, and a complete analysis for effectiveness in 310. Complete responses were uncommon. Major shrinkages of cancer, which are called partial response, that means at least half of the cancer goes away. Another 16% had what's called a minimal response, where less than 50% tumor shrinkage, but still shrinkage. And in most of the remaining patients, cancer was stopped progressing, often for very long periods of time, the average amount of tumor control being approximately 40 months or maybe a little more without the cancer growing. And if kidney protective agents are used and patient selection is paid attention to, it's usually generally well tolerated. And again, you'll be hearing a lot more about that over these meetings. And just one other treatment for metastatic neuroendocrine tumors I wanted to bring to your attention, a whole different direction, is for treating people with refractory carcinoid syndrome. Dr. Warner talked about some of the things that can be done as adjunctive treatments in addition to Octreotide when people have uncontrolled diarrhea. But a new drug has come along called LX1032 has been the name it's been given when it was investigational, which it still is actually. But it's looking very promising, a phase 2 study showed that diarrhea that was not being adequately controlled with octreotide could potentially be controlled with this medication, which works by stopping serotonin production. It's a whole different concept in inhibiting the enzyme tryptophan hydroxylase, which is necessary for the body to make serotonin. So it turns off the serotonin manufacturing machinery in the cancer cell. And as a result of not having the high serotonin, you don't have the complications of high serotonin, the diarrhea and flushing. So toxicity of this is quite minimal and it's well tolerated. I've kept my remarks to a minimum to allow some time for questions if Dr. Woltering feels there's additional time. Otherwise, we'll put all questions off until the panel discussion, and we'll just turn this right over to the next speaker. So I want to thank you for letting me share this.